Well, thank you everybody for joining us today for our webinar, What Education Reporters Need to Know About the Signs of COVID-19. I'm Allison Kowalski, I'm EWA's Membership Engagement Coordinator. So without further ado, I'm going to pass over to our moderator, Rachel Cohen. She's a freelance journalist who's been covering this topic for quite a while now, so she's really dug into all the data and will lead this conversation. So I'll pass it off to you.
Thanks, Allison. I'm really excited to be leading this conversation with such great experts. We have Sara Johnson, who is professor of pediatrics at Johns Hopkins School of Medicine and Bloomberg School of Public Health, and Falgunee Parekh, who is the founder and principal scientist of EpiPointe, which is a public health organization focused on epidemiological and clinical research around emerging infectious diseases. And thank you all so much for coming. I know we have a lot of education journalists and other people in the community here. This conversation couldn't be happening at a more important time. Yesterday, it was reported that a record 3,400 COVID-19 related deaths and over 113 COVID-19 hospitalizations occurred, both new records. The fact that we are in the worst state of this crisis, even as healthcare workers begin to receive their first doses of the vaccine across the country, puts all these questions around schools and school reopenings in a particularly challenging place. There's no question that for most students, remote learning is not better than in-person school for children's academic, social, and emotional success. Pediatricians in particular have been sounding the alarm for months about the harms to child development they worry might come from being out of school for so long. Education policy experts have been warning of so-called learning loss, and the fact that children seem to get infected less often and less severely has added a great deal of political pressure on leaders to get children back to school as soon as possible. Not to mention the fact that other countries have handled the pandemic very differently from the US, ranging from giving wage subsidies to businesses so they can close their shops to keeping schools open as long as possible. Although now we're at a point where even countries that kept their schools open longer are beginning to order closures in the wake of this current spike, like Germany recently announced. We know that schools are not just populated with children. There are many employees who work in school buildings in all different capacities, plus bus drivers and other personnel. This puts superintendents, mayors, governors, and others all in the position of weighing their responsibility to figure out how to protect those workers in those buildings, do right by children, and also right by healthcare workers, as there has been recently a major increase in pressure to flatten the curve as hospital beds become ever more scarce. We know that children can spread the disease in their households, are more likely to be asymptomatic, and that upwards of 40% of all COVID-19 cases of all ages are asymptomatic. There are many aspects of this conversation that can get relatively heated. I reported a piece back in late October for the American Prospect on why school reopenings has become arguably the most fraught debate of the pandemic. Some of it has to do with the fact that our federal government has really failed to lead a robust and comprehensive data collection effort. There's still inadequate testing and contact tracing. Congress failed to pass a relief bill that would have provided schools with more resources to implement some of the recommended mitigation measures. And there's just been a lot of mistrust, frankly, about what's happening in schools and mistrust around promises that school districts are making. This has a lot of implications for education journalists in particular, and listeners of this webinar are coming from all different vantage points. Some of you may be in areas where kids have been back in school for months. Some may have been open or now the schools are recently closed. Some of you may be covering hybrid learning or all virtual. So I'm glad to have a diverse group of reporters here, and I really invite you all to submit your questions when we get to that throughout the panel. We know this virus has had a disproportionate impact on Black and Latino families, and we know those families in particular have been more reticent about returning back to school in person. Some families say they want to return, but not until March or April when this current spike ends. Others want to get back as soon as possible. They're working, they need the help. President-elect Joe Biden says his goal would be to open the vast majority of schools by the end of his first 100 days, which puts us at the end of April. So this story about COVID-19 and its spread in schools is really complex. We are all grappling with inadequate data collection. Many of us have school districts in states that are not even disclosing the inadequate data they have collected. The journalists have played a really important role in pushing many places for better data disclosure. We are trying to reconcile what's happening in the US with experiences in other countries, even as those countries have had different COVID policy responses in many areas in addition to schools. We are trying to keep up with the latest research, and we are trying to capture the stakes of this moment and relay information in a landscape that we know is fueled by mistrust and misinformation. So all of that is to say, it's not easy, but it's critical in our job, and I'm honored to be here with my co-panelists, where we're going to hear a bit from them. I'm going to ask some questions that I have, and then we will try to leave at least 20 minutes, if not more, for Q&A from the audience. So, thank you. Falgunee, would you like to say a few words about your work and anything you kind of wanted to put out before we start Q&A?
Oh, sure. So, yeah, like Rachel said, I'm an infectious disease epidemiologist. I've been working on both a variety of infectious diseases globally, including malaria, dengue, Lassa fever, just all types of infectious diseases that have different modes of transmission. And, for us, as we're thinking about COVID-19 and how things have rolled out and how we move forward, I think that, as you said, Rachel, that data collection, having really good systematic data collection and surveillance systems set up is really key for decision making around schools and around a number of different issues that are related to COVID.
Dr. Sara Johnson, Dr. Johnson, would you like to introduce yourself?
Sure. I work at Johns Hopkins, and my job there, in addition to public health research, is as the director of the Rails Center for the Integration of Health and Education. So I think the introduction really nicely set up really some of these complexities about how do we get schools open, how do we keep schools open, how do we keep the people in buildings safe, and how do we respond to a changing landscape of evidence in a way that makes sense and that we clearly communicate that to all of the relevant stakeholders. And that's no small feat.
Thank you. And I should say some of the questions that I prepared, are coming with the assumption that many people who are watching this have been doing the hard work of trying to cover this issue for the last year. We're not the most basic level, although we are still trying to sort through some complex scientific topics. And so some of the questions that I prepared, it's not that I expect our panelists to be the, answer definitively these debates, but just to get their expertise as how they think about these questions that we ourselves are sorting through. So with that ahead, I will start. So the first question that I have, and I think many listeners have, is trying to think through, there are these sort of array of recommended mitigation measures for schools, and schools have, limited, they don't have all the ability to implement all of them. They are trying to figure out which ones are more meaningful and effective, which ones are not. Last week, the CDC put out a study estimating that the cost of implementing some school safety protocols would be between $55 to $442 per student. So that study didn't take into account any ventilation upgrades and focused on things like desk shields and disinfectant and more custodians and additional transportation. I'm curious to hear from you guys about, this question about air quality and ventilation appears to be one of the more important factors for transmitting the virus. There was a study that, in Philadelphia, a third of elementary school public school classrooms failed to meet minimum ventilation standards. So I would just love to hear from you if you could talk about some of the trade-offs of these different school protocols and safety protocols, and if institutions can't afford them all, where would you rank like upgraded air filters or so-called ionization systems on the importance scale?
Sure, I'm happy to start. And so our team at Johns Hopkins put out a curriculum or a set of modules designed for districts on public health mitigation strategies last week as part of the Consortium for School-Based Health Solutions at Johns Hopkins. And we sort of walk through all of these various public health mitigation measures. But I think what you've pointed out is really the crux of the issue, which is given scarce resources, how do we prioritize? And how do we understand if we don't have the resources that we need in buildings to keep transmission as low as possible? So I would say that some of the most important mitigation measures that we know of are potentially not very expensive, but some of them are logistically complicated. So I would put masks at the top. Universal masking, appropriate face coverings for everyone, I think is really important. And we've seen data that masks matter not just for kids, but particularly for teachers and other adults in buildings. So masks are important and probably among the cheaper strategies. Strategies to reduce density in cohort, I think, are also really important. Again, logistically challenging for the reasons that you mentioned, for example, busing and making sure that we can have A day, B day, or whatever the strategy is, or just spreading kids out in larger schools, but not as expensive. I think when we're talking about ventilation in particular, that exists on a spectrum and from low tech to high tech. So there are schools that are going to be able to open windows. Now, we have 6 inches of snow here in Baltimore, so I appreciate the fact that that's not totally straightforward in winter in cold climates either, but it certainly is effective to open a window. Also, portable air purifiers seem to be pretty effective and relatively lower cost than major ventilation upgrades. So I do think that there are strategies that are possible for districts with more constrained resources, and we need to be thinking about how to get all of the resources that schools need to them to implement them.
Yeah, and just to add on that, I agree. I think there are a number of different measures that we can use, and I think that specifically with regard to ventilation systems and things like that, even if we implement them, they're not going to be implemented in a vacuum, and that is the sole solution. We have to really, in order to really curb the transmission and put all the measures forth that can help us beat this pandemic, we have to use all the tools that we have in our toolbox. And so some of those are the ones that we already know about that are the most effective, right? Using masks, social distancing, washing hands frequently, and things like that. And so I think that the ventilation systems are part of that toolbox for sure. But there are also other measures that we can start implementing, sooner and more quickly than, having to potentially retrofit a school with new ventilation systems or things like that. So.
What do you think about thermometer checks? Because this is one that I know some schools have been doing. It was part of the CDC study. I've seen some articles say that it's not an effective measure, although for the couple times I've gone to the doctor this year, I've had to get my temperature taken in order to enter the doctor's office. So I feel like I've been getting mixed signals on temperature checks, and I'd love to hear what you guys think.
Sure. For the reasons that you pointed out, temperature checks are imperfect. We know that lots of people are asymptomatic, and so there are a lot of people who are going to be missed. There is no strong evidence in favor of symptom-based screening really at all, or to favor one kind of symptom-based screening over another. So, right, temperature checks are often accompanied by, do you have cough or other kinds of symptoms? That said, I think that many places continue to do them, and I think that we will pick up a few cases that way, and that's great. But one of the reasons I think they're popular and frankly they may be really important is that they are one very visible part of a much larger mitigation strategy, many of the components of which are invisible to folks, right? So, for example, when we invite parents and guardians to bring their kids back to school, they may notice the temperature check, and they may not notice the fact that the filters have been upgraded in the ventilation system. So it's a sort of a trust building, visible part of a strategy. Alone, I would say that is not a particularly effective strategy.
Yeah, and I think that when you're specifically talking about children, say we go in with the assumption that children seem to exhibit symptoms less frequently than adults. I think in that sense, temperature checks may or may not be effective. I also think that You know, a lot of times with viral infections, children exhibit different symptoms than adults do. And so maybe the temperature check is not actually capturing the correct symptom that a child might be exhibiting. And so I think that, again, kind of going back to this idea of in our school systems, we actually really need to have, you know, better data collection systems, better ongoing surveillance and tracking implemented so that we can really understand what are the measures that are effective in identification, in detection, and then also curbing the continued transmission once it's detected within a school. You know, one of the things that's been starting to be used at a lot of universities is wastewater epidemiology. So really checking the wastewater to look at, you know, viral shedding within a certain kind of, whether it's like a dorm or a closed building. And that's something that could be considered as an additional measure for detecting that's not as invasive and that's not as individualized necessarily. Like, you know, that it takes a lot of time to kind of say, let's check every single child and every single person that's coming in. While that is good and we should continue to do that because that's the tools that we have right now, there are certainly other measures that can be implemented that can help with detection, early detection and identification of a potential case. And when you have that early detection and identification, you are actually setting yourself for success in really curbing that transmission within a school setting.
That is one measure that I feel like has been discussed more on the higher ed level, and I'm curious to see if it will come to K-12 more, because it does seem to be a little more cost effective than some of these other measures we've been talking about. I wanted to also ask about social distancing. This is something I know as journalists we are sort of trying to reconcile often. There's been sort of a lot of debate about whether 6 feet versus 3 feet is sufficient for schools. The CDC has urged at least 6 feet, but the WHO and some prominent public health experts in the US have argued, like in the Washington Post, that 3 feet is sufficient, at least when community transmission is low, which it's not in many places right now. But I'm curious what you make of this, and how much of it do you think is trying to reconcile the fact that, as Sara was saying, it's logistically tough right now, you know, for schools to find that space available that want to reopen.
Yeah, I think it's a critical question, and the difference between 6 feet and 3 feet, I think, is kind of part of a philosophical discussion about, do we start at the most conservative end, or do we go push a little bit more towards what might be feasible? And I think as we try to build trust with parents, guardians, and community members, 6 feet is the CDC's guidance. We know that there's nothing magic about 6 feet. It's not that if you're 5 feet and 9 inches or 3 feet and 3 inches, you're going to be much off from those benchmarks. But more distance is better, and it helps us to facilitate dedensification. So I would say that while there are good reasons to move towards shorter distances for feasibility reasons, I personally feel that starting with that more conservative benchmark helps to bring everybody along. And I think that's really what we have right now, is a crisis of trust and trustworthiness, and we need to build from where we are.
Yeah, and I tend to agree with you, Sara. And I think, you know, I like to say, well, you know, 6 feet's better than 3 feet and 9 feet's better than 6 feet. And, you know, I think when we're looking at the guidelines and we're thinking about what are the CDC guidelines versus WHO guidelines, we also have to be really mindful of the fact that WHO guidelines may differ from CDC guidelines, because CDC may be much more focused in this particular situation on, you know, the context within the US, whereas WHO guidelines, they really are in a position to have to think within the context of a very diverse global population. And so there are different considerations that, you know, decision makers and policymakers at WHO have to take into consideration with regard to school settings and things like that in other countries. And so I think that when we're thinking about what should we do here in the US and what should school systems really think about, I agree that starting with a little bit more caution and maybe moving, having greater distance if it's possible to start with that. And, if we're also implementing, underlying systems of surveillance and data collection and things like that, we can start to evaluate what really is the minimum necessary. Right now, I think that it's difficult to really determine that in a real data-driven way. And so I agree that, if you can, 6 feet's great. If there are other things that we have to take into consideration, which I think in many settings there are things that we have to take into consideration, again, reaching back into that, all the tools in our toolbox. So if you're in a situation where 6 feet's not possible, we have to maybe have more stronger guidelines regarding mask wearing and social distancing, when you're not sitting at your desk, and washing your hands frequently and things like that. So all of these tools that we talk about, they don't occur in a vacuum. They work best when they're complementary to each other and, put to use together.
Yeah, and it's interesting because, we are at this point in the process where even for places that have reopened, oftentimes classrooms could be a quarter full or half full or maybe 60% full, which does make it actually easier to do the social distancing that, can help build trust or keep transmission low, but also it raises questions about, well, what would happen if we were back at 100% capacity, and we don't really have great examples in the US around that. So another question that I was hoping to ask you about, so some school districts are doing asymptomatic testing of students and staff, where they're, beginning to roll that out, which, seems like a good way to try to get at some of these asymptomatic cases that people are worried about. One challenge I've noticed in some of the coverage around this issue is that people seem to be comparing the rates of asymptomatic testing in schools with the rates of the broader city COVID positivity rates, even though those are testing very different populations, where if you go to your city's testing site, you're going likely because you have either had a known exposure or you are showing symptoms, so you want to get testing. But we are testing, we hope that if you are showing symptoms, you are not going to school, and therefore you would not be part of the group getting these asymptomatic testings. But I've read a fair number of stories that will say, oh, X city has a rate of 6.7%, but their schools only has 0.17%. Therefore, and sort of trying to draw conclusions that I don't think necessarily follow. And I guess I would love to hear from you guys how you recommend talking about school testing rates versus citywide rates, and how we should be thinking about those two numbers together, because they seem like both important data points, but I feel like there's been a little bit of confusion about how to compare the two.
Sure. So, much of the data that we're seeing city, county, and state level reporting is really based on cases. So that is usually people who are experiencing symptoms, or, as you said, have a known contact. And so it's really case-based reporting. And so when you're thinking about that and the fact that you're really detecting, and the reports that we're getting and all the numbers around the reports that we're getting, like the positivity rates and things like that, it's really based on symptomatic cases. And so we're not really getting at what transmission necessarily is. You may be, if you assume that all the cases are symptomatic, then you are. But we do have some knowledge that a pretty large percentage of cases in both adults and children are asymptomatic. So there's really a difference between looking at disease and looking at infection. And when we're thinking about transmission, you have to think about both, and you have to think about how you delineate between the two. So asymptomatic testing within schools, I think it's a useful tool, especially since we do have some data that shows that children tend to be asymptomatic. So they may be infected and they may be transmitting, and you're not detecting them because they don't have symptoms. And so it's really important to think about the difference between infection and disease, right? You are infected with the virus, you have COVID-19 disease when you start showing symptoms. But people who are infected are transmitters, and so they contribute, and they're highly relevant to transmission, continued transmission, and what's happening in the schools. And so I think especially within the school system, when you have children who may be asymptomatic, they're coming in, they show no symptoms, they're infected, they can still transmit. And so that transmission is going to continue and continue unless we're having some ongoing tracking within the school systems. And so again, doing the asymptomatic testing is a useful, tool. Wastewater epidemiology can actually capture asymptomatic cases, and there are, several different stories where at a university they were doing the wastewater epidemiology testing and they detected COVID, and they found out that there was one person on, such and such floor that happened to be asymptomatically infected, and they were able to, curb that transmission pretty quickly because they were able to identify that. So again, I think that those are things that we should be considering for our school systems.
I think we have to also be thinking, it's clear, and you highlight the right question, which is that we can't be comparing groups of people who seek COVID testing because of symptoms or because of a known exposure to people who are generally being tested as part of surveillance. When we think about surveillance testing strategies in schools, I think one of our great challenges remains the inequity in access to appropriate and adequate testing capacity to be able to facilitate that. So it's expensive and it takes a lot of tests. So we have to be able to do that. We know that testing frequently is really important, and that testing frequency in some ways trumps some of the sensitivity aspects of those tests. So we're really looking at a thoughtful surveillance testing strategy that can be really difficult to lift, particularly in places with constrained testing capacity. When we think about the comparisons between kids and adults, so more generally, I think our best data are coming from population level seroprevalence studies. And we do have quite a number of those to suggest that at least youngest children, 10 and younger, do have lower levels of infection overall, so prevalence of infection, than adults. But the data that you point to don't tell us that.
So I just want to make a call. So I'm going to ask questions for about another 10 minutes, and then we're going to turn to audience questions. So please do submit your questions if you have any. Thank you both again for your great answers. Another question that I had, a lot of states and cities seem to be looking towards reopening elementary schools first, given that it seems transmission may be lower there than in middle and high schools. But some existing data seems to suggest the risk, while may be lower for younger students, is not necessarily lower for teachers. And in some cases, we are seeing that the staff rates of transmission are also exceeding surrounding community rates. I would love for your thoughts on how we should be thinking about some of these discrepancies, especially in light of the coming vaccine, which is obviously very exciting and good news.
Did we lose Falgunee? Okay, hopefully she'll be back with us soon, because I'm sure she has comments on this.
Yes.
So I think you raise a really important point, and we do definitely see that when there are outbreaks in schools, they tend to be more commonly among staff, and they tend to be adult to child transmission on average and in general, although certainly child to child transmission does happen. So it's really important that we think about how to protect adults in school buildings. And so I think that's a critical question. As we start to look towards the vaccine, I think one of our challenges is to determine how we advocate for teachers and school staff to get priority access to vaccine. I think if what we really want to do is open schools, and I would argue that that is a national imperative to do that safely for everyone in the building, then we really need to think about how we might prioritize teachers. And a lot of that is around classifying teachers as essential workers. As you know, state to state, that varies tremendously. So I think there is a real opportunity for advocacy to try to get teachers to the front of that line so that we can give them time to build immunity and get folks back into classrooms who are appropriate to be there.
Just to clarify, are you saying in some states they are classified as essential workers, in some states they're not, or just that states have full discretion?
They have discretion about prioritization. So in some cases, the classification is independent of the prioritization. So in some cases, they're sort of second to healthcare workers, and in other cases, it hasn't really even been fully fleshed out. So there are some cases where that's a little bit more opaque.
Falgunee, I don't know if you want to add anything, but I was just asking sort of, this question about differences in staff to child transmission in schools and how to think about it in light of the coming vaccine.
Yeah, I agree with Sarah. I think that really thinking about where we prioritize teachers and other school staff when it comes to receiving the vaccine is really important. I think that, again, we can't ignore the fact that the vaccine has not been tested in children, right? I think that over 12 studies are just now getting started. And I think it's really important, to consider the fact that there are children who get infected, and there's still a pretty good proportion of children who are experiencing symptomatic disease as well. And some of them are experiencing severe symptomatic disease. So I think that all of these things need to be taken into consideration in light of the vaccine and in light of the availability and the prioritization of the vaccine delivery as we move forward over the coming months. Yeah.
So I know we've been talking a lot about, risks of transmission in schools. I did want to pose a question about, trade-offs about, are there risks to students at home, both, of course, academically and social emotionally, but also specifically for this panel, are there, COVID-19 risks that we should be thinking about and weighing in these discussions? And I would love to hear your thoughts on that question.
Certainly there are huge risks to kids in terms of social and emotional and academic growth. So I think those are pretty well documented, and we don't necessarily need to go over those again. There are risks to kids from being out of school in terms of long-term opportunity and their academic well-being. In terms of, are there specific risks to kids from COVID at home? Well, certainly when we get high levels of community transmission, kids are likely to be encountering it in their day-to-day lives outside of school as well, right? So certainly there is some risk of transmission in their homes or in their communities. And one question that remains unknown is, when kids are not in school, we make some assumptions that they're staying at home with their immediate family, but that may or may not be true depending on the opportunities, resources, and needs of that given family. So it could be that our adolescents are continuing, for example, to go hang out together during the day, and we may not actually be preventing that much mixing. So I don't think we eliminate COVID-19 risks by closing schools, for sure.
Yeah. I mean, sure. I think, every action, depending on what it is, can put you at varying levels of risk for infection. And I guess I'm not really sure, Rachel, are you kind of talking about risks to children as a result of COVID-19? So risks to other kind of educational and developmental issues, or?
Well, I guess I just wanted to, I was curious. I think as Sarah said, the audience to this webinar is pretty well versed on the academic and social emotional harms of being outside of school. So I was just curious if there was any additional epidemiological context you think that we should be thinking as we're weighing these conversations? I know personally, back in the summer, there was some writing where people worried hybrid schooling could actually be worse from a spread standpoint because it's increasing, the number of contacts, but there are obviously also arguments in favor of it if it can keep class sizes smaller. I think in terms of, I know I just asked about children, so forgive me, I'm just going to throw in staff a little bit to this conversation because I have seen, I've seen some people say that any, transmission, to the extent that there are positive cases in schools, those are just happening, those are probably just happening in the community and not happening in school. I am not sure how reliable that, analysis is given what we know about, contact tracing and so on thus far in the United States. But even still, I'm curious, I guess I was curious about maybe safety benefits, if there are safety benefits to children from a COVID-19 perspective of going to school, but also, I think a lot of educators worry they would think they are not safe they are less safe in school than at home. And so I just wanted to open the space up for you to weigh in on sort of either those concerns, if there is any disadvantage from a transmission standpoint to having kids not at school. And I think Sara made the point, well, they may be congregating elsewhere. We don't really seem to have good information on that.
Right. I mean, I'm going to give the epidemiologist response, right? And I think that all these questions are really, really valid. And what I think is the way that we can answer them is to have, again, better data collection systems, better surveillance systems that are targeting our school systems. So that I think that when you have a potential case that arises in a school, in a student or in a teacher, we can then start that process of contact tracing, and then you'll really be able to have a better idea of, well, how many people were really in contact with that person in school and outside of school. So I think that there are a lot of these questions can actually be answered through having better data collection systems that are really targeting your school systems, and that actually feeds into what we are seeing in the community as well. And I'm going to apologize right now. There are some people doing lawn work outside.
Oh, can you hear that? Awesome. Well,
I would just say, was just gonna say one more thing about that, Rachel, which is that there's some evidence, at least from Europe, that when sometimes schools have opened and schools are the only thing open and other things are closed, that is the primary setting where kids mix. And so really there's an awful lot of mixing happening in that point. And we still see that schools tend to be below levels of community transmission in younger kids. And then we see higher levels of transmission. Even despite all that mixing, we definitely see protective effects for younger kids, but higher levels of virus for older kids, so high school students and staff. So I think we have to think a little bit about what the differential risks might be by age, depending on sort of what mixing means and how big of a risk it is. It's different by age.
Yes, and I'm glad you brought up that. I didn't have a chance to ask about some of the international studies. I hope some of our audience members will. If they don't, I will do that. Allison, hey. Are you gonna send the questions, or where should I?
Oh, no. We're ready for audience questions. Just to remind everybody, we have some questions in queue. If you want to add yours in, put them in the question box. Remember to put your name and affiliation. So I'll kind of start it off with this first one from John Fensterwald at EdSource. He asked, could you discuss the science behind surveillance testing? Should all students be included? How often should testing of school staff be done? I know we kind of touched upon this earlier, but maybe to kind of refresh everybody, since this has come up a couple of times in the questions box.
Sure. So, in epidemiology, there are different types of surveillance, right? There's passive surveillance, there's active surveillance, things like that. Usually in outbreak situations, a lot of it is focused on contact tracing. I think that we're so far into the pandemic at this point that we really do have to think about something that's beyond just case-based surveillance for our school systems because of what we know about infection and what we know about pathogenesis, particularly in our pediatric populations, with having a high proportion of asymptomatic infections and things like that. So, we are in a situation in the pandemic that we are, of course, always concerned about an individual person who is infected, who has disease, who is sick, but we're also very much concerned at this point about curbing the transmission and being able to stop that continued transmission. So I think that, again, there are tools that we can be using to do more active surveillance within our school systems. And, this is not reinventing the wheel, right? There are surveillance systems that exist that can be modified for school systems. And I think also having the school systems really think about personnel and resources, like getting back to a situation where we have nurses at every school. I'm old enough to be of the generation where that was the case. There was always a nurse at school, and not every place is like that anymore. So I think that having those kinds of healthcare workers that are sitting within the school system can be really, really helpful as well in detecting, in case detection, in surveillance, because how many times has a parent been called by the teacher or the nurse at school and said, hey, I just don't think your kid seems right today. They just don't seem like their normal self. Those things count for things when you are looking at asymptomatic diseases, because even if it's asymptomatic in terms of having fever or having some of the traditional symptoms, viruses can still run you down. And that's something that's not as easily detectable. But we do know that our teachers and our, school staff are often very good at just seeing that in the children that there are in the schools. So I think that there's a lot to be said about implementing those types of systems within the school and really having that be systematic so it can be comparable from school to school and from school system to school system as well. And so that all the school systems can be learning from each other. And what I see right now is that some places have implemented some things, some types of contact tracing, others have something different. And so we're not really able to learn from what's happening in Illinois versus what's happening in Washington so that we can be helping each other, inform each other. But having something that's a little bit more standardized, that's systematic, will really kind of, I think, contribute a lot to enabling us to curb transmission and get to a point where schools can operate the way that they want to be operating.
Can you also, we have a question, just clarify too for the audience what we mean when we say surveillance testing?
Sure. So, so do you, I guess, can you clarify the question a little bit?
Oh, just like a basic definition of like when we talk about surveillance testing in like schools, just to make sure that reporters are on the same page about what kind of metric or what kind of measures those are actually referring to.
So you're really looking at number. So there are different ways that there are different measures that you would maybe implement into a surveillance system. And I think in this situation, you would probably be thinking about number of cases and number of infections, which are two different things, right? Cases are symptomatic cases, and then infection is those who are infected but maybe not exhibiting symptoms. And then of course, contact tracing. It's, I think, a really big deal in any epidemic situation, especially in a pandemic like this, that we cannot ignore the importance of contact tracing and continuing to try to do that. Especially when we're talking about a kind of like a closed, defined, I shouldn't say closed, but a defined population, that we can do that contact tracing within a school. So Yes.
I could just I can just add on to that, just specifically related to surveillance testing. So when we're talking about surveillance testing for the virus, specifically, we're talking about we're contrasting that to symptom or exposure-based testing, right? So if you have a reason to go get tested because you think you might have the disease, then you're going to go get exposure-based testing. Surveillance testing is done for anybody regardless of symptoms, and our goal is to determine whether or not there are people who have no symptoms who might pop up. The timing and the frequency of that testing is, I think, a matter of a lot of scientific discussion. There's a preprint recently that compared 2 weeks, testing everyone every 2 weeks versus every week versus every 3 days, and they compared different strategies. For example, our sort of gold standard PCR testing versus antigen testing, which currently is not approved by the FDA for asymptomatic testing. But there have been a lot of efforts to try to figure out how do you trade off the sensitivity and the specificity of the test with how often you need to give it and in what populations. So I think we're still trying to optimize outside of schools what's the best way to do surveillance testing.
Thank you. I appreciate the clarifying, and I know the audience does too. And kind of following up with that, we have a question about knowing that a lot of this surveillance and everything is kind of imperfect, and schools are all putting in their kind of cutoff at certain percentages. Are there current recommended health metrics that can indicate schools should be going to in-person learning or not? Camille Phillips asked, in her community, the positivity rate is currently above 15%, and their local health authority is recommending parents keep kids home, but the schools also remain open and school leaders say they're safe. So can you kind of talk through the tensions of those, and if reporters are facing a situation like this in their community, what do they need to be taking into consideration?
Sure. I think this is one of the most thorny challenges. There have been a lot of case rate based guidelines. CDC, for example, has them on daily case rate about sort of what is your highest versus lowest risk of transmission in schools, and how do you operationalize that accordingly. What we're increasingly seeing is that school districts are moving towards sort of empirical evidence from their own schools. So schools that are open, whether that's in really small ways, right, whether they just have a handful of students back or they're open in more robust ways, they're really trying to track in their own school systems or their school buildings what's happening. And so I think many schools are shifting towards trying to determine whether or not, if they have different districts have different cutoffs, if it's one case, 2 cases, 2 independent non-linked cases, 2 linked cases, whatever it happens to be. I think a lot of folks are saying, well, we are seeing really high community transmission rates. There's no doubt about that. And that does create a significant risk for everyone. But often what we're seeing is a disconnect in that many of the schools are not seeing significant transmission within the schools. So I think that that's a challenging place to be for school district leaders when they are not seeing evidence within their school buildings, with all the imperfect tools we have about surveillance as a caveat. That's perhaps encouraging schools to be a little bit less stringent with a specific case rate based definition of when to open or when to close.
Thank you for that. And I think kind of the next question then goes into more of, I know everyone now has questions about the vaccine rollout, and Dale Rostikoff put in a question about if teachers are designated as essential workers, can you envision when schools could safely reopen? If teachers are vaccinated, presumably students still would have to wear masks, maintain distance, etc. And I know we had kind of talked about this, and I know you can't predict the future and there's only so much you can say because it varies state by state, but kind of touching upon that vaccine question, what do and don't we know about how this could potentially roll out?
So I think that we have to remember that the vaccine, similar to the ventilation, is not the panacea, right? It is, again, one of the tools in the toolbox that we're using to combat this pandemic. And so you have to have the vaccine, but that doesn't really eliminate the need to use masks or the need to do the social distancing or anything like that, because you can get the vaccine, you can still get infected, right, when you have the vaccine, but you won't get disease. But you could transmit even as a vaccinated person potentially. I mean, there's some things that are still a little bit in question with regard to that. So I think that, again, it's really important to remember that all of these things are part of the toolbox, and we need to use them all together to really, bring that transmission down.
Sarah, did you want to add anything to that?
No, I think that you're absolutely right. Because it's very state to state, we don't have a kind of uniform rollout for a vaccine for anybody currently except healthcare workers. I think there's still lots of open questions about vaccine in schools and what will uptake be, right? We have lots of work to do to determine what proportion of teachers would get the vaccine, whether or not that will be voluntary or mandated. I think those are really, it's too early to even necessarily guess at those questions. But I agree that as we start getting into the vaccine process and we get a growing fraction of teachers vaccinated, we're still going to have to keep many of our mitigation measures in place and then slowly start sort of backing away from them as we get closer to herd immunity.
So backtracking a little bit, we have a question from Charles Lessier, who's from the Advocate newspaper in Baton Rouge, Louisiana. He's talking a little bit back to that question of if you have a school district that isn't really giving a lot of data out, if they are not really reporting things, and you have to kind of do both sides. His question is, do you see or do you need to see a consistent and broader reporting of school COVID data? But I think also it's a helpful question of if your school district isn't giving you a lot of great data, what other sources can reporters go to make sure that when they're reporting, they can have hard numbers to back it up, or at least some sort of measure to talk about their district if, they can't get hard numbers. And maybe Rachel, you could speak to this too, because I know you've had to do a lot of reporting on this.
I'll let Sara and Falgunee take it. I think people want to hear from them more, at least right now.
I think that's a really tricky question, and I think we certainly advocate that school districts are as transparent as possible within the guidelines of privacy that they possibly can be, because I think that information is critical for decision making, both kind of at the broader district level as well as for parents and caregivers and teachers to understand really what's happening. So I think a lot of daylight on this process is really important. In the cases where there is no daylight, I think that's a really challenging problem. You can certainly go back to county or district level reporting through public health agencies, but you're going to get a really skewed picture for the reason that Rachel talked about earlier, right? Is that you're often looking not at surveillance testing, but you're looking at folks, adults typically, who are going because they have symptoms or an exposure. So to the extent to which that's going to tell you about transmission in your school is limited. I think it's also really dependent on what's the makeup of the school. What do we know about what's happening in the school in terms of mitigation and density and all those other things that make it a little challenging to predict.
Yeah, I agree with Sarah. I think it's a tough question to answer, and I think that it would be nice to see that the school-based reporting is rolled up into city and county and state reporting, and that can be de-identified. So that's something, I guess, to think about, as well as why is that, even if it is just case-based surveillance reporting within the school systems, why is that not rolled up as part of the overall city, county, and state level case reporting? I think that's something to think about, something to consider as a question that I have. But I do think it's tough, and I think sometimes it's okay to say we don't have the data really, and sometimes we just have anecdotal information and we go off of what we have and what we know, and sometimes those are things that we use as lessons learned to say, like, this is anecdotally what we know, and this points to the fact that we really need better data collection on this.
And I guess the one thing I'll add on that point is just that sometimes knowing what we don't know, at least for reporters, is the way to know if a politician or a superintendent or someone is making claims that we know is not supported by the data they've put out, which unfortunately we've seen they sometimes do. They're not, immune to the whims of politics and other things. And so it can be helpful to at least, it's frustrating that if we don't know what's going on, but at least we can be able to check if our leaders may be saying things that extrapolate further from what we do know.
Yeah, I think that's really helpful for all reporters to keep in mind. And I thanks, Rachel, for adding that to this. So we do have one clarifying question for Sara from EWA's Eric Roblin. He just wants to reinforce from earlier, were you saying that you endorse the emerging strategy by schools of focusing more on incidents in their school rather than in the broader community?
Well, I think that I don't think it's necessarily focusing on, I don't necessarily endorse one or the other. I guess what I'm saying is that is increasingly where we see a disconnect between some of the strategies that different school districts are using. So some of them are relying purely on case rate or test positivity based cutoffs, and that they are opening closing based on that, and others are focusing on what's actually happening in their schools. I think what's happening in your schools can be incredibly informative, but it also needs to be balanced against the fact that often we don't have surveillance testing or other kinds of things. So I don't know that it's an advocacy as much as it's just pointing out the differences in the landscape.
Thank you. And we only have a couple minutes left, so I like to always end on this question. Our audience is primarily targeted at education reporters. This is going to be an ongoing story as schools are continuing to use new data and as the vaccine rolls out. But I would like to know, based on all the reporting we've seen so far this year, and as reporters have been trying to keep up with it, can you either give a story that you think hasn't really been covered yet on this topic, or anything that's like a narrative you think is misinformation, or maybe you see kind of popping around that isn't really getting at what's going on?
I would say very broadly that I think there's a lot more work to be done around trust and trustworthiness of our institutions. And I think that that's generally true as we start to think about vaccine. We've certainly seen vaccine hesitancy from all corners. And what is it going to take to help rebuild trust in our systems of data and reporting, in our public health system, in order to help parents, caregivers, and others, teachers, feel safe as they come back into the schools. And I think that trust and trustworthiness is really at the crux of that, and that intersects, I think, with lots of questions around equity. I think for many historically marginalized communities, this is an even bigger question. It's beyond vaccines. It's about who has the standing to tell me what's best for my child and who has my child's best interest at heart. And I think we have only begun to scratch the surface with some of those issues, and we're going to be grappling with them for a really long time, well past when COVID, it is mostly resolved and we can get kids back in classrooms.
And for me, I think that, we now can clearly see what I think people in public health have always known, is that education is a key driver of the economy. And, are we investing in, as we're kind of looking at the response and all the issues that we're grappling with right now, are we also investing in preparedness plans for the future? Because today it's COVID and tomorrow it will be something else. And so we really need to be thinking about preparedness plans for schools, for school systems, for the next time this happens, and what are the steps that are going to be taken, and what are the resources that schools really need to be prepared in the future. And so that's something that I think is important, and also what resources are going to be put towards investing in and implementing preparedness plans for school systems. And it's really not that different of a conversation to what we're talking about globally on a country level as well. You know, we really just need to have stronger preparedness plans and really take the lessons learned for the future.
Thank you. I appreciate we are at time right now, so I just want to say thank you again to our panelists and moderator. This has been a really helpful discussion, and of course, the webinar recording will be made available for anyone interested, usually up on our site within 48 hours. If you want to go back, this is on the record, so you can quote from them. Also, if you are logging out right now, we ask please take that survey. It's only a couple of questions, and it really helps us figure out what kind of content you want to see from us. But other than that, thank you again so much, and I hope you guys have a great rest of your day.
Thank you.
Thanks.
Thank you.